Describe an approach to treatment of patients with RP. Step 1. Make sure to institute general measures such as heat conservation and cold protection. Counsel regarding the need for tobacco cessation. Consider stopping potential offending medications, e.g., beta blockers, if medically feasible. If general measures are not effective, use medications. Try to use only during cold months. Step 2. Start nifedipine XL 30 mg per day, amlodipine 5 mg per day, or diltiazem cardizem CD, Dilacor XR 120 mg per day. If no response in 1 week, increase dose and continue to titrate subsequently every 2 weeks until maximum dose. Nifedipine XL 180 mg per day, amlodipine 20 mg per day, cardizem CD 360 mg per day, or Dilacor XR 480 mg day, or side effects develop. Step 3. Add topical nitrates, sildenafil or prazosin. What can be done medically in patients presenting with acute ischemic crisis that is digit threatening? Step 1. Put to rest in a warm and quiet environment in the hospital. Step 2. Control pain. Chemical sympathectomy, digital lidocaine block, and consideration of narcotics. Step 3. Start one of the following vasodilator therapies: CCBs, amlodipine 5 to 10 mg, or nifedipine XL 30 to 60 mg, and titrate. Intravenous prostaglandins, epoprostenol or iloprost if available. Step 4. Antiplatelet therapy with aspirin 81 mg per day. Step 5. Anticoagulation with heparin during acute crisis can be considered, especially if antiphospholipid antibodies are present. What surgical options can be performed for patients who are refractory to standard therapy? Chemical sympathectomy via a digital lidocaine block can be performed promptly in the office for patients with acute episodes of ischemia and pain. This may provide lasting benefit beyond the temporary relief of the anesthetic. Chemical sympathectomy with botulinum toxin A has been described as well, but data on efficacy is conflicting. Recently, a small randomized trial failed to show clear benefit. Surgical sympathectomy may be considered in patients in whom more conservative measures have failed, and who are at high risk for digital necrosis and other ischemic complications. It is commonly performed at either the superficial palmar arch, the common digital arteries, or the radial and ulnar arteries. Sympathectomy may not provide long-lasting benefit. The majority of patients with secondary RP due to SSC have vascular disease that is prominent at the level of the palmar arch and distal digital arteries. However, a small subset may have proximal vessel compromise that is discovered by an abnormal Allen's test. In this setting, angiography to identify occult disease at the ulnar artery, or less commonly the radial artery, should be performed to determine if the patient would benefit from surgical revascularization. In patients presenting with dry gangrene of a digit, it is preferable to avoid surgery if possible and allow the necrotic area to clearly demarcate from viable tissue proximally. Allowing the digit to autoamputate preserves the greatest length possible of the involved finger and avoids surgery at a site with compromised blood flow. Surgical resection may be required in some patients with concern for infection and/or intractable pain. What is the prognosis for patients with RP? The prognosis for patients with primary RP is excellent. In 10% of patients, attacks disappear completely. The vast majority of patients with primary RP never develop an underlying condition such as those associated with secondary RP. This is especially true if NCM and autoantibody testing are negative, less than 2% progression to SSC. The prognosis for patients with secondary RP is generally dependent on the underlying condition. Intrinsic vascular disease is often present. Complications arising from vasospasm such as digital ulcerations are common.